everyone. Welcome to the Evidence-Based Design Journal Club. We're so happy you could join us today. I think you'll find this topic today to be very interesting. Just as an introduction, I am the host, Sheila Bosch. I am the Director of Research at Gresham Smith & Partners, where I lead our evidence-based design efforts. And just a reminder that the reason we do the Journal Club sessions really is to engage a much broader community in reading, analyzing, and applying the results of evidence-based design studies into our real, everyday lives. So just so glad you could join us. We do offer both EDAC and AIA CEUs. So to receive credit, you can actually download the forms at any time by clicking on the Show My Media library icon, which is in that top toolbar where the red arrow is pointing. Excuse me. And you'll have access to AIA quiz, the EDAC form, and also today's presentation slides. To download a file, just click on the green arrow next to the file, and when you're finished, click the double right arrow in the top left corner of the media library, and the library will close, and the slides will refill the empty space. For EDAC credit, complete the verification form and retain that for your records, and you will need to submit that to CASEL Worldwide at the time of your renewal. And if you need AIA credit, please complete the verification quiz and a CEU management fee of $10 from the CHD store, and submit the verification, and I'll sign Shannon's email address on the forms as well. So let's get started. We are really blessed today to have two outstanding practitioners and researchers. We have Laurie Wolf. Laurie is a Lean Six Sigma Black Belt and a certified professional ergonomist with a master's degree in human factors engineering from the College of Industrial Engineering at Virginia Tech. With 19 years of healthcare experience, her work in occupational medicine has increased productivity, lowered injury rates, and reduced compensation costs, worker compensation costs, by implementing innovative ergonomic solutions. And her best practices program in slip and fall prevention actually won a research partnership award from the National Institute for Occupational Safety and Health. Our second author is Eileen Costatino, and Eileen began her nursing career at Barnes Jewish Hospital in 1977 as a staff nurse in orthopedic surgery, and then several years later she joined the Nursing Quality Assurance Department, and she's been involved in process improvement for nursing services ever since that time, with an emphasis on patient fall prevention and restraint reduction. As senior coordinator in the Center for Practice Excellence, I coordinate Hospital Fall Prevention and Restraint Reductions Program. Thank you both for joining us today.
Thank you. We're glad to be here.
It's really good to have you. So as I mentioned, we are hosting this event to really get people engaged in the dialogue today over fall prevention, and we're going to look at specifically fall prevention for inpatient oncology using lean and rapid improvement techniques. This was published in the fall of 2013, and hopefully we'll get to hear some of what you've been doing since this article was published towards the end of the session. But we will have a very active discussion, I hope. And I'd just like to say I'm really excited about today's topic because those of us in the design community tend to focus so much on the impact of the built environment on health-related outcomes that sometimes we forget that design is only one important piece of the puzzle. And it's really imperative that we all seek to understand the organizational culture, the operational processes, patient factors, intrinsic, extrinsic, staff issues, the list goes on and on. There are a whole host of variables. And ultimately, the design needs to really support initiatives such as those that you have implemented here. Now, I'm going to go ahead and hand off the slide advancing to the two of you, and just go ahead and get us started with a little bit of information on this project that you've conducted. It's a really excellent case study, by the way.
Thank you. Okay, looking at that first slide with some of the statistics about falls, they really are not only a problem in the community, but also especially within the hospital. Patients are admitted generally similar to how they were when they were at home, and then we give them medications, and they are in a strange environment, which makes them more vulnerable to falling and potentially having a serious injury. It is, if you actually went to the CDC, the center, their National Center for Patient Safety, you could also get statistics about leading causes of death. And they basically break them out into fatal deaths and non-fatal. And for the population 65 years and older, it is the number one. Falling is the number one cause of fatal and non-fatal injury. And for all ages, all populations, so that's an infant all the way up to 80-plus years old, it is actually the third leading cause of death. So it is a national problem. Many, many hospitals have been working to improve this. We are all compared nationally on our rates, and Barnes-Jewish Hospital, along with many, many other hospitals, have had a really long journey with this and it's been continuous ongoing work to try to improve our rates, and ultimately with the goal of keeping our patients more safe and free from injury.
Do you find that people are actually surprised when you tell them that falls are the most common cause for non-fatal injury and hospital admissions for trauma? I would think, it's got to be car accidents or something.
Right.
Those are the crazy drivers.
Yeah, actually, for all populations, poisoning is the number one, and motor vehicles is number two. But and I think that's true for the rest of the community. And some patients even they don't think that falls are something that are going to happen to them when they come into the hospital, and they somehow feel comfortable and confident that they're here and that we'll keep them safe.
Good point.
So this was actually a system-wide initiative. Barnes-Jewish Hospital is a member of a 13-hospital group within the system. And this was the Center for Clinical Excellence, which is part of BJC, actually got this initiative started. And they looked at particularly falls with injury throughout the system and what units had the highest rates of falls and falls with injury. So that's this slide represents those in that box are three of our oncology units. And that's how this initiative got started, was really within oncology. And it was a rapid improvement event, but it was implemented not only at BJH, but additional hospitals within our system.
That's really interesting that 3 of the 4 are oncology patients. Do you have any idea why that would be the case?
Yes, and that's probably also true nationally as well. Oncology patients inherently, due to their disease process, particularly whether it's a primary cause or metastasis, especially if it's bony disease, their bones become very, very frail. We've actually had a couple of cases where patients literally just stood up, and because of that force of standing up, they've broken a bone. So that's how frail their bones are. Also, chemotherapeutic agents, the toxicity of those agents, and particularly at Barnes-Jewish Hospital, we do a lot of protocols and a lot of testing. So those agents are very toxic to the body, and they cause problems with your bone and weakness. But in particular, it's because of the coagulopathies, the clotting mechanisms within their body are not, they're very decreased in the oncology population, which makes them more at risk for bleeding. Even if they were to get a laceration, that would bleed and may require a transfusion for that. If they fall and strike their head, a greater potential for them to have a bleed in the head, which can be fatal. So it's sort of inherent to the diagnosis, and it's inherent to the things that we do to that patient in the hospital that cause them to be more frail, more weak, dizzy, more sleepy from the narcotics, the medications that we give them to prevent some of the side effects and symptoms.
I actually had chemotherapy 20 years ago, and I can tell you just the exhaustion was just, like, incredible.
Yes, absolutely. And I think patients don't always understand they came in fairly healthy, and they don't always understand that these things are going to happen to them, and hence they're going to be more at risk for falling.
Okay, we wanted to give you just a little background about the environment that we're in and get you understanding that there were 3 different divisions or floors, but they're very similar in layout to this the image that we have on the screen here. But I wanted to start by just helping us understand and come with the same agreement on a definition of human factors. I use human factors and ergonomics interchangeably. And what I mean is it's a scientific discipline that helps us understand the interactions that humans have with the equipment or their environment or the system that they're working in. And our goal is to use principles and data to help us design an optimized environment that achieves well-being and safety for our patients and our staff, as well as helping them have efficient performance in whatever task they're trying to achieve. So that's a definition that's well accepted by the IEA, International Ergonomics Association, as well as the Human Factors Association here in the United States. So the environment that we're working on, as Eileen alluded to, the complexity of the patient is enormous. It can change from hour to hour. Just even the same patient can have different issues from one hour to the next. As well, we have constantly changing staff. During our event that we're going to talk about, during the 17 months, we had 43% turnover in our staff. Our management completely changed. We often have conflicting processes going on at the same time. So in addition to their risk of falling, we have other conflicting medical treatments. So the reason they're taking that medicine is because of the treatment that they need to have, and that treatment is what is making them dizzy and sick. So we have conflicting issues all the time, and even the environment itself changes. So to refer you to the diagram here, it's the long hallways. This is a very old building with long traditional hallways with patient rooms on the outside here, nurses stationed in the middle, so it's a little bit like an H. But there's not a clear big hallway on this one side over here. So the red X's on here indicate 1 year worth of falls on one floor. So that means this red X, a fall happened in that room. And you can see that they're clustered around the nurses station here, but that is where we tend to put our highest risk for falling patients so that we can get to them quicker. The barrier between the nurse station and the hallway is actually right here. It's just one little skinny doorway, and so you can see more falls tend to happen here. So even though they're all close to the nurse station, they're still harder to get to.
That makes a lot of sense.
Okay, so that's a little bit about our environment. Okay, moving on to our next one. So as Eileen mentioned, we did a rapid improvement event. We did this event in 3 days, and we got all the key disciplines together for a focused event on falls. We had 3 different oncology divisions. We had representatives from management, nurses, physicians, technicians. We had pharmacy was an important player, occupational and physical therapy for rehab, anybody that we thought was critical. We even had housekeeping come in for part of it.
Patient.
We had a patient there also. And we spent 3 days, The first day, what we try to do is get us all on the same page, understanding the urgency and importance of this event and why falls should be important, even though they have many other medical tasks going on. Falls has to be an important one in there. We use something we call a solution tree to actually get the voice of the staff nurses that weren't able to attend in that room. We got their voice by putting up this tree a few days ahead of time in the nurses' lounge where they could tell us what they felt like their biggest barriers were for fall prevention, as well as any ideas for solutions that they had. So it was a way to bring their voice in, even though they weren't present in the room. And then we began understanding our current state and figured out where we wanted to be in the future state, looking at the gaps between them and how to brainstorm solutions to fill those gaps. Then second day, we tried to implement some of those solutions. The third day, we began our standard work in order to give us materials to train all the nurses. There were at least 50 nurses on each floor, so that's about 150 people to train. Wasn't done during this event, but we had prepped in order to be ready to train the nurses. After the event, it took us about another month to train all the employees that had to be trained and understand what we were trying to implement.
Before you go on, we had a question from Lisa Platt with Plaintree, and she says that, the study indicates that patients were instructed not to get up without assistance, and she was curious, is this part of the oncology patient orientation process or part of the staff training, or how did that work?
Yes, especially that came to light, I think, in our rapid improvement event. I think prior to this event, there was, from the staff, there was sort of a generic understanding. Yes, it's part of our normal admission process that we talk about falls and how to keep them safe. But it wasn't where it needed to be. It was more of here's how you use the call-away, here's how you get to the bathroom, this is where that's located. It wasn't brought out to be its own discussion, its own conversation with that patient. And that is what we really realized during this rapid improvement and have really been focusing on since that time, that it is truly a conversation that you have to have with that patient about their specific risk factors for falling and for a fall injury.
It needs to happen throughout their stay, in addition to orientation. I like that they're oriented in the very beginning upon admission, but they have so many things going on at admission and oftentimes hear devastating news. We find that message needs to be conveyed little by little throughout the entire stay.
And not only with patients, but with the staff. So it's part of their huddles. It's part of their unit practice committee meetings, their process improvement processes. Anywhere in their staff meetings. It's integrated. It's really a part of that culture.
Thank you.
Okay, during the rapid improvement event, we focused on 3 primary areas. The first is assessing the patient in a brief screening so that we understand what their fall risk is. The second is focused on what kind of interventions are appropriate based on those screenings. And then the third category was what to do with the information after a patient fell. So it involved a post-fall huddle, a whole accident investigation, and what to do with that data. So we're going to go into a little detail about each one of those 3 components to show you what it looked like of what we evaluated during the week.
And these are some of those factors I was talking about earlier that we just have to consider whenever we're thinking about the design. We've got to also think about these others. It's a whole big package that goes together.
So we didn't have a whole lot of control over equipment and environment, but what we could do is focus on the processes and the awareness of the patients and the staff. But we'll get into a little bit about the equipment that we did address also.
So this is, as Laurie mentioned, there were 2 components of the assessment. And I think it's important to point out, from a nursing standpoint, they do assessments. But basically what you're seeing on the screen, these are really screenings. They are not, our therapy department does a much more in-depth mobility, balance, gait assessment. So this really helped drive if there was a referral needed, particularly with regards to mobility. But these are what's on the screen is a couple of examples of what that screening assessment was, looking at cognition and particularly using the Get Up and Go tool, which is a widely used tool out there to assess that patient's ability to move about in a safe way. And and we may talk about that a little bit later, but the repetition with that cognition screening, patients complained about that because this was something that was being done every shift. So we later on actually did not use that cognition assessment as in-depthly as it is on the screen.
We did condense that into defining and standardizing how we assess for alert and oriented times 4. So the 4 questions that we asked, we made sure they were asking those in the same way.
Right.
So we kind of simplified that, I guess.
Yeah, much more.
And that's need to read the fine print here, right? This looks complicated, and it probably is, but give us a simplified version of this algorithm that you used.
Sure. So basically, and this too couldn't be incorporated into our electronic medical record, and to this day still is not incorporated into our electronic medical record. So we laminated this. It was right near the computer. So as they were doing their risk assessments, documenting their cognition and mobility assessments, along with the rest of the fall risk assessment, they were using this as a guideline to decide what interventions would be needed for that patient that had specific risk factors. So in looking from a design perspective, for those in the audience, if you look at the use of bed alarms and the use of a bedside commode or gait belts for a patient that's at high risk for injury, they will need a type of bed that goes very low to the ground along with a floor mat. And what that floor mat, it sits right next to the bedside if the patient were to fall to the floor, because most of the falls happen around the bed, then that's a cushion. And there's actually been research done by the VA to show that, yes, these mats, these cushions, do prevent serious injury. And they present their own design challenges. So when they're not in use, that they need to be accessible, not only in the patient room, but also on that unit. So where are they stored so that they are easily accessible by the staff? But when you need to take them out of the room, where do you put them? Reducing clutter, so you can't have all these pieces of equipment around. So from a design perspective, where can they be stored within that room as well as on that unit with easy accessibility? And that's just a continuation of the algorithm. You don't have to, if you're interested in seeing that, we'll be happy to send it to you in a format. What we would love to do is see this integrated within our electronic health record. And we are actually moving to a new electronic health record throughout the system coming in, I think, probably 2017. So we hope to be in that conversation how we can get this integrated.
Now, the interventions that you've all implemented are really multifaceted, and I'm hoping you can explain the approach in a little more detail and tell us about some of the other tools that hospitals might need to reduce patient falls that might help.
So we're going to move to this slide just because this is kind of represents that issue. That when you look at the literature, there's very few studies that actually isolate one individual intervention. Most of them are in a bundled approach, and certainly our hospital has tried many of these bundles. It's hard to separate out exactly which intervention helps. We think that ultimately it's a combination. It's a little bit of culture and getting to know the patient for sure and customizing those. We don't think there's one bundle that fits perfectly for all patients. So we are trying to go with a more individualized approach, which means you have your interventions that are available to you, but it has to be matched to the capability of the patient. We're over an emergency room.
The think your ED is going to be full here soon.
We thought that it's important to bring that home, that idea that the bundles are okay, but it's not the only thing. The environment alone won't fix it. The yellow socks on a patient and an armband will not fix it. It has to be a little bit of combination of everybody, and so much the awareness and culture of the nursing staff and the housekeepers and anyone that walks in that patient's room, as well as the partnership with the patient, because we mentioned how complex it is that our patients, if they're newly sick, they don't know what the medication impact is. Maybe they come with a story of how they got to be in the hospital. They may be perfectly fine that morning, but they're weak because we give them medication after they enter the hospital. So we need to understand what that patient's story is in order to customize an intervention that's appropriate for their fall needs.
I think, too, to segue on to Laurie's, that is a challenge for all hospitals. The interventions, there really isn't a lot of new stuff out there. I think we're always looking for, innovation. We're looking for something new, like that silver bullet that's going to really help us drive these numbers down. And there are some new technologies, some smart technologies out there. And I think another, from a design perspective, to really keep that in the back of the mind that, is cabling there to allow us to be able to put into some of these smart technology that might assist with this problem.
Okay, these pictures just represent a post-fall huddle, we called it. It's just an interdisciplinary group of people that were involved with the direct patient of care, directly with the patient if they fell. So after a patient fall happens, the nurse that's caring for that patient gets together with whoever else was on the team, a physician or a therapist, to try to understand what happened. There's some short-term things that need to be done quickly so you can understand things that might change, like if they fell over some clutter in the room, before that clutter is moved, we get a picture of that or something on the floor, we can understand what that was. And then some other things that are extracted from the medical record, what kind of medicines were they on, over what period of time. Those things can be done a day or two later, but we try to get this done as quickly as we can, and then ultimately post it on the wall so everyone can see. This had all the information about a patient's fall right in the hallway, so the nurses walk by it and they can see how many patients have fallen, when they last fell, what kind of interventions were in place when they fell, or was an intervention recommended but not in place. That was also enlightening. But at one glance, we can easily see what happened with the falls.
I think another point to sort of touch to that, what other hospitals can do. In that picture, you see Kathy Limbaugh. She's pointing to the tracking board. She was a true champion, and I do think that that's essential for anyone trying to implement either within the hospital, within that unit.
Good point.
You do have to have a champion. Doesn't necessarily have. She was not a leader. She was an advanced practice nurse, but she really dove into this with all of her heart and her mind. And I think that's essential, is you have to have that champion.
So I'm curious, how many iterations of that form did you have to create?
A lot. The snapshot that's in the article, I believe, is the final version that we ended up with. Although from time to time we still make some changes. Kind of depends on the focus of the floor, but it has to meet your needs. So the data has to come from your floor. So when we're talking about that bundled approach, figure out what your specific injuries are. And a lot of our injuries happen with toileting, unassisted toileting falls. But we found that through this data and making things transparent. Okay, we mentioned that Lean was used as the technique in the Rapid Improvement event. One of the tools in Lean is standard work. And so this is the way we organize our standard work document. It was developed during the event and used to train all the nurses in the month after the event before our go-live date. And this it's a little hard to read here, but it has just the steps that it takes from a time a patient's admitted, and you assess them, this step-by-step process here, as well as pictures that go with it. So this is step one, assess the get up. This is assessing the go. It even talks about how to document the fall risk assessment and all the components to think about of cognition and altered elimination and cognitive. So all these screens show up here. And then we taught the patients according to these screens. So this is just a visual of standard work for this specific project. Then in addition, we also looked at equipment. We mentioned that it was an older unit, so we didn't have a lot of control over the environment specifically, but we did control some of the equipment in there or found the frustrations with the equipment. One of the reasons we did this is that this was a very old environment that's moving to a new building, so we wanted to identify all the pain points with the old building to try to incorporate into our new design as best we could. So we mentioned that toileting was an issue. One of our very frequent problems is IV poles. We have some thresholds in the floor, that threshold between the patient room and the bathroom, and that's hard to pull the IV pole over, and we find lots of tipping. It's very top heavy and easily tips over when it catches on a threshold. We also had a big frustration with our call lights. The nursing call lights in the beds don't work, and they're supposed to use a pendant, and then the call light on the pendant will fall down between the crack in the bed, and it's just difficult for the patients to remember to use the pendant and not the light that's right in front of them.
And a lot of patients, when they go to the restroom, they have to walk a distance. And on this particular unit, where this picture is, the place where they unplug it from the wall and plug it into another outlet, and those outlets were located so low that too promoted a potential fall just from that fact.
Yeah, they lean over to plug in the IV pump and get dizzy.
Tom Clark asks a really, I think, an important question. You know, there's the whole issue of, and the question of whether or not having the grab rail from the bed to the toilet and the toilet room on the head wall, does that really reduce falls or not? And his question is, so in your rooms, in these oncology units, was there a continuous grab bar? Did you find that there was stuff between the bed and the bath?
So we have spent hours and hours discussing this. So in this particular room, remember they're old rooms, there were many obstacles between the bed and the bathroom. So usually the bathroom is on the head wall side, but there were so many things in between, and you have to go around a corner. There'd be a sink in the way, say. Some of these didn't even have sinks in the bathroom. The sinks are on the outside, so the patient's having to shimmy around the sink to get into the bathroom. So that is not the layout that we have in the new building. But so all these discussions were around the trade-off between having a handrail continuous from the bed into the bathroom for, say, frail patients that need to have the handrail versus the bathroom being across so it's visible. So for a patient with cognition challenges, they can find the bathroom because they see it from their bed. So that has been the ultimate design challenge that we have been debating, and we've looked at the literature along with Center for Health Design. Has been an amazing help in trying to put that literature together and what does it mean. They've compiled experts all over the country, and it's still a toss-up. I can say our new design, they came up with an innovative approach that the bathroom is on the head wall side, and they are experimenting with different kinds of handrails now. They're trying to find a continuous handrail. But in addition, they moved the toilet to the side so that from your bed you can at least see inside the bathroom into the toilet if the door is open. So that way, they tried to kind of compromise between the two design features. So that's a wonderful question. That I'm not sure there is a final answer. It kind of depends on what kind of patient and what your environment is. Okay, then we have tracked the results of this study. This happened way back in 2011. So we have the baseline that we started out with. We mentioned that our corporate division is the one that spearheaded this initiative for our specific hospital, so they tracked a baseline for us. But we've been interested over time, what does that look like? And you can see it's kind of up, down, up, down. Overall, the trend is that it did decrease total falls, and we did decrease by injury rates, both at a statistically significant level. Along the way, there were a few little things that changed. We try to keep things constant so that we can, as best we can, see the impact of what our assessment, intervention, and data tracking were. But you can tell that with our employee changes that happened, we did have some new low beds that were implemented down the road, but we do try to track our trends over time.
That's great.
And then because this has been so ongoing, and falls is a dynamic thing that you're just never done with falls. It's not like you implement a program and you're finished. This study happened 3 years ago. We've been tracking our progress, but we've also been doing other interventions since that time. So we did some work on Six Sigma, trying to drill deep. We had all this rich data. Now we did a Six Sigma project to really understand why our falls were occurring. And then we did some individual patient interviews to understand the patient perspective. All of that led to this initiative where we boiled down what we thought were the top 5 most important things to convey to your patient. And Eileen has spent probably a year putting this initiative in place.
Yeah, we actually had what's called a fall summit. So that was back in January of 2014, and gathered a very large group of professionals together, multidisciplinary professionals. We broke out into 5 different groups, and one of those groups was, because we had signage for fall prevention and before, but one of those groups was really focusing on our signage system. Historically, we've always had signs. We've used yellow socks and yellow armbands, and as a result of that group from this fall summit, we developed, along with communications and marketing, and went through multiple committees for approval, and it was really based on that partnering concept that we do have to have a conversation with our patient about their risk factors for fall and fall injury. And this particular sign is what is shown to be a moderate risk. So we utilize the Johns Hopkins Fall Risk Assessment Tool, and that is the patients who fall. 40% is for all of the hospital. If you were to look at an oncology unit, it would probably be closer to the 80s. So patients are getting up by themselves, and it typically has to do with going to the restroom, something to do with toileting. So the emphasis is really we need to focus on that patient, assist them more for those patients that are at moderate risk.
And I like how this ends. It says, we have the time and we're happy to help you, because often the patient perceives the nurse is too busy and they think I can just get up and transfer over to the bedside commode, and they really do need to call for help. So it's the nurse's job to make sure they're available and not give the impression that they're feeling too time pressured.
So this went live February.
Okay.
Yep. So we're continuing on.
Okay. So let's go to what are some of the results that you found? Let's summarize. There were the design implications. Really, it's I think you can probably attest to the fact that healthcare designers really need to ask questions like, what are the safety interventions, the process improvement interventions, what's going on, and bring the folks like you into that design process really throughout the entire process, I would imagine. Would you agree?
Absolutely. There's so many different people that interact with that patient in that unit, physicians, therapists, and pharmacists, and they all tend, nurses and patient care techs, and they all tend to have their own agendas, so to speak, and it's really bringing that group together to understand what those agendas are, get all of those things out on the table, so that from a design perspective, you really can say, okay, let's see what we've got here. What can we do? What are our financial as well as our design implications? And just you've got to get everybody in that group to talk about it.
What do you have? You talk about toilet height here. Did you come to a conclusion about what the ideal toilet height would be for the inpatient?
This one was interesting because we had therapists in the room, remember? And what we had thought was that the toilet should be high enough that it's easy to get up and yet fit the patient's legs. But the therapists, in some cases, liked it normal toilet height or lower because that was what they're going to be getting used to when they go home. So therapy almost used it as a therapy exercise almost, getting up and down off the toilet, where we were wanting it to be a little easier to get up and down. So I think the specific height depends on who you're talking to, and I don't know that we came up with one exact height. Do you remember that?
No, and I think there was some discussion, should we get, they have extenders that can go on the toilets to make them higher. And that was a whole other discussion, looking at the vendors and what types they are, and really couldn't agree on one that was both safe as well as that met their needs. Generally, what people do is they bring if they need to elevate the height of that toilet, they will bring the bedside commode into the bathroom. That is what kind of the standard practice is, and that bedside commode will sit over the toilet without the bucket, and then they have handles to actually hold on to.
Okay. Tom asked also, have you tried using a wheeled walker with brakes, kind of device at the bedside to help the patient from the bed to the bath?
Another interesting question. When we presented our this project at various venues throughout the hospital, and I remember specifically one of the executives, C-suite executive, asking, why don't we just put a walker in everybody's room? And while that may sound realistic and possible, that too is a very, very individual decision. And that walker needs to be, therapists have to look at that, teach that patient, they adjust the size. And sometimes, as we found with walkers and bedside commodes, just the presence of them in that room tends to entice the patient to use them, where that's great. And that's kind of the juxtaposition with falls, is we want them to be mobile and get up, but we also want to help them when they're not able to do that safely on their own. So sometimes that equipment in the room can be dangerous.
Remember, we had that one nurse that she commanded all the bedside commodes be kept in the bathroom so they're not visible to the patient, so they have to call for help.
Yeah.
So it's just two ways of looking at it.
Mm-hmm.
So you've learned a lot. So you didn't have much control in this study over the environmental conditions. You really learned a lot about the environment, but what else did you conclude from this case study?
It's very complex. Falls are very, very complex. So many intrinsic things within that patient themselves, and also extrinsic things that impact that. As Laurie mentioned earlier, there is no one cookie cutter thing that you can do, or even a bundle that you can do. It really does need to be looked at individually. And any time, I think, we've tried to do processes, we tried to make them as simple as possible. Nurses are very busy, and this is just one thing that they have to deal with. So you have to simplify that, incorporate whatever they're doing into their normal everyday work. And unfortunately, this type of a safety issue it does require critical thinking because it's so individual to that patient. So while you have a sort of checklist in the computer of things to do, you really need to think outside of that box and say, okay, specifically for this patient, what needs to happen? As Laurie said, you can't just not look at this anymore. It's never fixed. It's always has to be on the radar, always has to be on the front burner, and it requires constant attention and talking about. It's just something that won't ever go away. We will never ever eliminate falls totally. There are those falls that we can prevent. There are things we can do to prevent, but patients are going to accidentally trip over things. We can't avoid that. But how in the room can we make that safer? That if they were to do that, how can we make that safer? And I think that's from a design perspective.
Or also provide enough space
exactly.
that they can have assistance all the way into the bathroom.
Absolutely.
Sometimes the spaces are so tight
right.
or around the edge of the bed, there's not room for a caregiver to be side by side with the patient. So
right.
that's another design
yes.
benefit
yep.
to help us get assisted falls. We found that they're 4 times more likely to be injured if they're unassisted when they fall.
Right.
So we can decrease at least the injuries from falling if we can't stop the fall itself, but decrease the injury if they're assisted.
And I think the other bullet point there, return on investment and the payback, is probably not seen directly. So some of these design things that we put in place, you may not really see that investment initially, but and you may not ever realize what this piece of design that you put in you may not ever realize that. But thinking more holistically and sort of big picture, it's promoting a safer environment within that room, especially around the bed because that's where the falls happen the most, but also within the toilet area. And absolutely, as we found, we did have some leadership changes during that process, but your stakeholders, the leadership, if you don't have that engagement, if you don't have that champion, or the nurses who are the ones who are going to have to actually implement these processes, if you don't have them on board, that's very, very critical to the success.
Elizabeth Henson asks if you can talk to to any findings related to eliminating thresholds in the flooring.
Yeah.
Any of them any better than the others, or do you have any opinions that you can share?
Yeah. So as we mentioned, this has been in the older environment, it was a real challenge and still continues to be a challenge because we don't have the right flow of the water into the shower. It comes out, so we have a threshold to get into the shower to hold the water back. So that's a continuing thing. But we have found some retrofits that seem to work by gradually tapering the height. What it is, at least our issue, is the tile in the bathroom causes about a half an inch lip down into the regular tile on the patient floor. So one of the extenders they've done is to slowly, gradually go up. It's about, maybe a foot. Mm-hmm. They taper that threshold almost a foot, 12 inches down, so it's a much more gradual slope as opposed to a lip that tends to catch the IV poles. But you also need to watch that. Even that little gradual slope, one patient said, it feels like I'm climbing Mount Everest up that slope and pulling his IV poles. So sometimes they're just so weak that even that threshold fix is difficult. So ideally is if we can create the design in the beginning so that there is no thresholds, that's what we found the best. And we have some of our newer designs that are able to achieve that. But there is always that trade-off then of no lip into the shower, then the water coming out. So it seems like there's always trade-offs and design decisions that have to be made.
Absolutely. Kristen asks, too, also, did you notice or track or measure any reduction in staff injuries, actually, that corresponding with the decreased fall rates, I guess, from the injuries from lifting those patients up off the floor? Did you look at that at all?
You know, we did not in this study. I spent 13 years before I started doing my Six Sigma Lean work working with human factors and staff preventing work comp injuries. And so that's an issue I'm very interested in. I think it's essentially not nearly researched as much as it needs to be, is what's that crossover benefit between patient safety and staff safety. I think we have a lot to learn there, and even integrating our interventions together, like where's the interaction between lift device and patient handling and fall prevention. They directly go hand in hand, and for that matter, even pressure ulcers. So we move the patient correctly and safely for both patient and staff, and decrease the risk of falling, because now if you fall, you have a lift device there. So that's a wonderful question that I think we need to do a lot of improvement on, working on. That's one of my plans to move into that field a little better.
Excellent question.
That'll be very, very helpful.
Mm-hmm.
Now, let's, with every study, it's constrained by time and money and all of that. What were some of the limitations of this particular study?
Well, falls are self-reported, so that is, we're relying on staff to tell us when a fall happened, and that's always a limitation with anything. So there may have been falls that happened. The patient may have fallen and didn't tell the nurse, hence the nurse didn't report that. Or we even found variation in the definition of a fall. Patients sometimes think a slip or a trip, well, that's not really a fall. I don't need to tell anyone. They can feel very intimidated by that. It's a sign of weakness. So maybe patients don't tell us when they fall. And then staff, they might still, I think there is somewhat of a punitive, sort of a guilt associated with a patient fall. And so there might be some limitations with them actually reporting that. And then, as I think Laurie mentioned, all the other interventions that were going on. As we had our director of the oncology services changed, the manager changed, our lead charge nurse. In fact, I think during our project, after it was a year, we had one member that was a consistent force, and that was our advanced practice nurse. So I think just all the changes, it's constant. Patients are constantly, particularly on this one unit, oncology unit, patients, they were 35 patients a day would be discharged and admitted. So that's a lot of activity. Aside from staff, they generally only work, 3 days a week. So you've got a patient having a nurse for 3 days and then someone different, pulled staff. So there's a lot of activity and change and going on. So I think that was definitely a limitation for us.
We had another question come in from Phil, and he wants to know that since so many falls do occur as part of toileting, have you implemented any processes where the patient can specifically request toilet assistance that may be provided perhaps by someone other than the RN? Maybe they don't feel as guilty asking, someone else to help them. Have you encountered that at all?
Especially in the oncology patient, particularly if there's a private room, families are usually there and basically stay. With the new design, there will be a place for that patient to actually, or for that family to stay there as a to help out with their loved one. So families are very, very involved particularly with oncology patients because of the nature. It's kind of a devastating thing to have to deal with. But so the other piece to this that we didn't really touch upon too much was once the nurse did the screening for the get up and go, therapy would often be referred, and requires a doctor's order for that referral. Therapy would come in and do their more specific assessments of gait and mobility, and they would actually, during this project, would determine if the family was okay to help that patient with their toileting. So we got them involved, and initially, although it didn't really go over too well, we had therapy post a communication sheet that was for the nurse and for the family to say, yes, they are. They can get up. They need one-person assist, two-person assist, and family is actually capable of doing that for them. So family plays a pretty critical role when they're involved. Generally, for the other things, it's usually, instead of the RN, it's going to be the patient care tech. And I think there's some opportunity we're even talking about that in our hospital, about secretaries and other care providers, sitters, what can they do to help with this problem as well?
We'll have, I think, time for this one last question, and Donna Lee Anderson asks if in the design for the new facility, was there discussion about the location of the nurse station based upon this study and what you found?
So I have to say I'm not an expert at what the new process will be, because we have not been involved like a day-to-day stakeholder. We talked with the architects about a year ago and mentioned what we had found in this study. So I can't really say how it's going to come out now, but certainly where the nurses station has been a key discussion, and it's mainly about whether it's satellite nursing stations, like working in a pod where maybe instead of one long skinny hallway with one nurses station, maybe you have 3 or 4 pods along the way. So in theory, the nurse has patients assigned within a room or two of each other, and then they chart right outside the rooms. So there are, what do they call them, like launch pads where they can document and yet look into 2 different patients' rooms from where they're sitting. So they certainly have thought about that and how does the structure flow. Yet if you look at the culture, the nurses tend to like to be in one nursing station and maybe not liking the pods as well. But part of that is it's a whole process and a system. You have to assign the patients in a correct way for that pod system to work. So if I'm assigned 2 patients on one end of the hall and just because of workload or assignment, I have a patient at the other end of the hall, all of a sudden it doesn't work and it's more convenient to be in a centralized workstation. So all these things have to line up together, and it's not the design and the process and the way we use it all have to match up to make it all work.
And interestingly enough, this particular unit that we've been doing a lot of work on, they did, given the floor that they have now, it's still old, they did implement pods. They did some construction work and implemented pods. So they now have 4 different pods in addition to that centralized nurse station.
That was some wonderful work, very creative, out of taking an old environment, retrofitting it with these newer ideas.
I see an awesome study in the works there. It's a great net.
It never ends.
Well, I just want to thank you both, Lori and Eileen, for this really interesting session on falls and for all the great work that you do. I would like to just do a final reminder that if you'd like to earn continuing education credits for this session, download the form found in the media library. For AIA credit, you will need to purchase a CEU management fee for $10, complete the CEU verification form and quiz, and email it to Shannon Reckline. And I would like to just thank the Center for Health Design for making these sessions available and free to anyone who wants to participate. Also to the Herd Journal, typically that supplies access to the articles that we discuss here on the Journal Club and make those available for free. If you haven't already subscribed to Herd, I recommend that you do that. And your feedback is very important to us, so if you could take a moment and complete the quick survey at the link at the bottom of this slide, that would be perfect. This concludes our event, and thank you again for joining us. Have a great day.
Thank you.
Thank you.
Thank you.